biggest source of pharmaceutical pollution by far is actually us. Because when you take a drug, typically somewhere between 30 to 90% of the active ingredient passes directly through you, unchanged, unmetabolized, and directly out the other end when you go to the toilet. And so that then makes its way into the sewage system and out then into the natural environment. So in most places it's going out into the waste water. Lots of places use the sewage as, manure fertilizers in agriculture. So then that's going into the crops and into the groundwater. Various drugs which we know are quite disruptive to all kinds of different organisms.
Hello and welcome to Planet Critical, the podcast for a world in crisis. My name is Rachel Donald. I'm a climate corruption journalist and your host. Every week I interview experts who are battling to save our planet. My guests are scientists, politicians, academics, journalists and activists. They explain the complexities of the energy, economic, political and cultural crises we face today, revealing what's really going on and what they think needs to be done. These are the stories of the big picture. Go to planetcritical.com to learn more and subscribe. My guest this week is Martin Hensher. Martin is a health economist and a professor of health system sustainability at the Menzies Institute for Medical Research at the University of Tasmania, where he investigates how can we develop healthcare systems that do not overshoot Earth's planetary boundaries, which parts of our healthcare are critical and necessary, and which parts may be causing harm, and how can we degrow the healthcare industry whilst keeping the many benefits, such as our increased life expectancy and dramatically reduced infant mortality. This is an astonishing episode. I cannot believe that I haven't done an episode on health in the 4.5 years that Planet Critical has been running, because it may not surprise you to know the healthcare industry is another symptom of our overconsumption. And there's a lot about it that will need to change if we are going to stay within our planetary boundaries. Martin begins by walking us through the relationship between increased spending and added value, revealing that there are elements of healthcare that actually undermine our health. He tackles the question, how much healthcare does one person need? Explaining how our health has evolved since the agricultural revolution, the many benefits that have come from a dramatically increased spending on healthcare, particularly in the past 80 years, before revealing the health issues that actually increase due to ecological and social degradation. He explains which parts of our health are already being impacted by climate change, including the number of deaths that are happening annually due to climate change, and reveals the ultimate tension that if healthcare is tied to economic growth, how do we maintain our healthcare systems whilst degrowing our economies? Martin then explores the many different cascading factors that are connected to our healthcare industries, such as our pharmaceutical pollution. And by that, I mean the pollution that comes from our own bodies. The fact that we are becoming increasingly resistant to antibiotics, or the fact that many of our most potent drugs are found in critically endangered areas deep within our most precious jungles. And he ultimately comes to the conclusion that we will be able to have a healthcare industry that saves lives and prevents disease, but it will have to look radically different to the healthcare system that we have today if we are to stay within our planetary boundaries. I hope you all enjoy the episode. If you do, please share it far and wide. And if you're loving the show, become a patron on Patreon or support Planet Critical with a paid subscription at planetcritical.com. By signing up, you'll get the Planet Critical newsletter inspired by each episode delivered straight to your inbox every week. You'll also have access to the wonderful Planet Critical community who are full of inspiring thoughts, ideas, critiques, and determination. The links are in the description box below. I'm so grateful to everyone who chooses to support the project. I'm a vehement believer in ad-free and open access content, so Planet Critical wouldn't exist without the direct support of the amazing community. Thank you so much to all of you who believe in Planet Critical and keep the project going every week. Martin, thank you very much for joining me on Planet Critical. It is a pleasure to have you on the show.
Likewise, lovely to be here.
My first question for you is, why is the world in crisis?
Excellent. Start with the easiest question. So I think my answer's really got very little to do with my field per se, so we'll get on to health later. But I think, as I think about this, I think it's got a lot to do with, firstly, greed, which comes from the kind of acquisitive instinct, the way Ian McGilchrist talks about the sort of the grasping reflex, So we got greed. Then we also have cleverness, which has given us, this amazing capability to do extraordinary things. But it's also given us this extraordinary ability to kind of rationalize bad behavior, really. And, which has led us into the whole, kind of greed is good caricature, and really how we can justify all the sort of extraordinarily destructive things we're doing. And I think at the same time, and connected to that, we've had the whole kind of problem of, disenchantment, and particularly, really a loss of virtue ethics in a very old-fashioned way of thinking about it. And I think they've all come together as our capabilities have increased and increased. They've come together and self-reinforced in really rather terrible ways, and all the current crises of sort of inequality, the kind of multi-leveled ecological crisis and the meaning crisis, I think really all fall out of that, actually.
Well, I'd have to agree with you in many respects. With regards to sort of dressing down the human character and its many flaws, that's a very good summary.
Which is not to say that we're not also capable of extraordinary things, and I think that's the tragedy, and I do actually think that's why the kind of the ethics dimension is so important, really, because I think without some different ethics, we're not going to get back on track and actually realize the extraordinary potential that we do have as humans.
Yeah, I completely agree with you. The perversion is built into the system of organizing, which means that those who are the most grasping are the most rewarded, rather than the most punished. So.
No, indeed. But I think, but more than that, they and many others are actually able to convince themselves that this is good. That this actually, this will bring the overall betterment of humanity, etc. And I think that's that horrible rationalization. And, that's when we talk about denialism and things, I mean, obviously you have the sort of actual climate denialist and stuff, but really that's the fundamental denial and lie, I think, is in all of that rationalization of what is actually obviously quite bad. Part of that has just come through my, personal, professional kind of journey, but also actually, I've been a Christian for quite a good few years. And when you really, as you dig deeper into the theology and thinking, a lot of this stuff actually becomes much clearer. And there have been many, many attempts by people who today would argue that they too are faithful Christians, engaging in just this kind of rationalization to go 180 degrees from what is actually, the original teaching. So it's kind of everywhere. It infects everything. And actually these, some of these themes, it's sometimes in the kind of circles in which we're talking, often people are a bit nervous to talk about religious themes, etc. But actually things like, the fall and all of this sort of stuff actually have a deep resonance, I think, with some of what we're talking about here.
Hugely interesting, especially because normally on my show I'll sort of most normally do a bit of a rant about Judeo-Christian sort of systems of knowledge and beliefs that led us to this particular point in time. But I do agree with you that there's a huge amount of almost like warnings built into these texts, which I think goes to show that the human character has not evolved that much, frankly, over the past 2,000, 3,000
Definitely.
years.
Very much. We are very much who we always were. Absolutely. Absolutely. Yeah. Absolutely. Yeah.
Now, Martin, I did bring you onto the show to discuss your work as a health economist.
Yeah.
And given you are the very first health economist I've had on in 4.5 years, I would like to push us in that direction. And so if I can sort of take your first answer to the first question, this like
Yeah.
grasping reflex,
Yeah.
how can you say that does or doesn't apply to the health industry? Because you've written really interesting stuff about how even the health industry needs to degrow, which is sort of something that I'm not seeing very much of at all with regards to the specificities in industries, especially one that we consider as sort of life-giving and caregiving, and something that maybe seems quite frightening to begin to limit resources going towards.
Yes. Okay. So I think kind of what's drawn me into this whole direction of, thinking this way about healthcare. I've worked in healthcare and health economics, my whole career, kind of as a sort of regular health economist, kind of health policy person for much of that time, but maybe in the last 10 years, really moving into, degrowth, post-growth, sufficiency, whatever you would like to call it. I struggle to find the right name for myself, really, the label. But yeah, in the last 10 years or so, I've really started to think about that. So I think, firstly, I think healthcare is just the most fantastic example, actually, of all the things we're talking about in, degrowth and post-growth, this whole kind of field. Because, on the one hand, a great deal of modern healthcare is unambiguously fantastic and has brought enormous benefits to humanity, starting with the kind of the basics like childhood vaccination, but even up to the very cutting edge of the latest technologies. These are extraordinary things which can give people longer and better and healthier lives. So there's this enormously important part of healthcare, and it's something that touches almost everybody. Unless you live really in the very poorest, very remotest place conceivable in the world, you're going to have had some contact with healthcare. And if you live in a rich nation, you're probably going to have very significant contact with healthcare over the course of your life, particularly, as we get older and as we move towards the end of our life. So it's something we all experience. Yet on the other hand, it also is a fantastic example of how you can have too much, and you can have too much consumption of some goods, and you can go past that point at an individual level as well as a societal level of having too much, and it starts to become, certainly to not add any extra value to your health, and perhaps be even further down the track, can actually become net harmful. Too much healthcare actually can start to undermine your health quite easily. So that's kind of drawn me into this space, because it's actually a fantastic example of all of this stuff, and in a funny way, because it's for two reasons: because healthcare is so essential, but also actually because we're quite good at measuring people's health outcomes and health status in a way that, it's much harder to measure the social value of fashion or, upholstery or something, isn't it? But health and healthcare, we actually measure that quite well. So in some ways, we're beginning to be able to sort of investigate where are some of these kind of inflection points, where is it, on the way up, what is still actually giving you more and more and more real benefit as you deploy more resources into health. When does that start to turn, and when do you start to lose those benefits? So it's a really interesting, super example. And, it is, in most rich nations, it's 10% of the economy. In the United States, it's 17 to 18% of the economy. So in its own rights, it's just like a massive sector. That's just healthcare. That doesn't include things like, aged care, social care, disability care, those things, which are another, 4 or 5% of the economy again in most high income countries. So it's like a big old chunk of the economy. So just for that reason, it's important, and it's especially important because in an aging world, we are going to see more rather than less need for healthcare, not because exactly that older people are less healthy, but simply because obviously you use more healthcare towards the end of your life, and the absolute number of older people is growing and growing, and they're going to be a bigger chunk of the population, going through the next few decades. So healthcare, whatever you do, especially I think in a degrowing economy, let alone in today's economy, healthcare is probably going to end up being even more of a chunk of the overall economy as we go forward. So all that I think makes it super important.
Can you give me some concrete examples of how too much healthcare can undermine your health? Let's start there.
No, sure. So that's a good. So that's a really nice place to start. So first of all, let's think of a nice kind of simple example, like maybe think about screening. So we have all kinds of different screening programs, often particularly for different cancers. So we know some screening programs. So for example, screening for breast cancer has been really quite effective, really good. Everybody, we can argue endlessly about what exactly are the right age cut-offs, etc. And so one of the things that has happened in breast cancer screening, which unambiguously is a good program, is, generally speaking, once we see that a health technology works, there are very strong pressures to kind of expand access to that health technology. Some are, fairly directly financial, in the sense that somebody's usually making money off, giving people more drugs, or, building more breast scanning machines, etc., etc. So there's pressure to sort of expand it. So there's been a lot of debate about, we started with kind of later middle-aged women, but often cutting off at age 65, because that was the group who were unambiguously most likely to benefit, were most likely to get the accurate detections, etc. And then obviously it's tending to expand outwards in either direction. So even something that really unambiguously is a huge success, like breast screening, you've got kind of around the edges. We're always nibbling around the edge of, well, how much of this? Think about another imaging example, though, of something.
Hang on, wait. I don't understand why that would undermine your health.
Okay, it does. Well, no, that wouldn't necessarily undermine your health. So I'm come on to the next example,
right, okay.
where, so that's an ambiguous one, because breast screening, basically, it's, if anything it picks up is likely to be malign in some way. It may or may not necessarily be a cancer, but it's, going to be something that then going to the next stage of having, minor surgical interventions, aspiration or something, is very unlikely to cause you any damage and might well do you some good. But then let's think of another possible example, which is a sort of much more contentious, is on the same argument that it's good to understand what's happening in your body, and the early diagnosis will let us move quickly to early treatment, and that will therefore, kind of is almost like a prevention argument, that early diagnosis allows early treatment. We've got this trend now in many countries where commercial companies are offering basically full body MRI scans. Okay, so full body MRI or CT scans. Now, they will potentially show up if you do have, sort of early stage cancer malignancies. They possibly will show that up. But what is actually also becoming clear is, as it goes on through your body, it absolutely will, for everybody, pick up some anomalies. Okay, so like, sort of nobody over the age of about 30 comes out of a full body scan without having picked up something. And once you've identified that something, you're then on a kind of slippery slope of, well, what are you going to do about it? And what then happens is people get caught up in what they call diagnostic cascades. So we found a sort of anomalous, don't really know what that is, or we'd better have a look. So then you start having more diagnostic interventions. Perhaps you start having surgical interventions. So we start doing lots of stuff to you, even though we weren't even looking for whatever that, whatever that abnormality was at the beginning of this process. And particularly once we start doing anything surgical to you, anything that involves, inserting things into your body particularly, then every time we do that, there's a non-zero risk, at least, of causing an infection, as well as possibly, some other kinds of injury, with puncturing something that we didn't want to puncture, etc. But particularly of a risk of infection. So then you're onto, at that end of the spectrum, you can be on this sort of horrible trajectory where we've started to do interventions for something that we have no idea whether that original abnormality was going to ever cause you a problem. And for some portion of people, and it's not it's a non-trivial proportion of people who suffer sort of some level of complications from particularly interventional medical care, and then so that can then cause you injury, make you sick, and then that can, for some people, that then multiplies, and just you get, if you're very unlucky, you have a kind of whole cascade of really bad outcomes. So that's kind of two opposite ends of the spectrum. So really, in an ideal world, we would obviously only ever do any kind of intervention for you if we could be absolutely sure that you really needed that intervention, and that any risks of you having that intervention were more than outweighed by what the benefits of that treatment would be. So I mean, clearly, as I say, whenever you have surgery, there's there is a non-zero risk that you're not going to come back from the anesthetic. And that's fine, because for most people, the reason you're having surgery is because it is either imminently or eventually going to be life-saving. So it's entirely reasonable that you take that quite small risk, but it is a real risk. However, if we're operating too frequently at kind of, if you like, too low a threshold, then we're actually every time we're exposing people to a constant risk, but those people actually, their chance of benefiting was smaller to begin with. So somewhere, we get down into, we're exposing people to a real risk of harm, even though what we were doing for them possibly wasn't ever going to benefit them. So that's the theory. The very hard practical part, of course, is in terms of an individual patient in front of you or a wider population. Well, where are you on this spectrum, given that you've shown up? And okay, I think you might. I think we've got your diagnosis, but what is the right threshold? So that's super interesting. And then when we, if you like, you can think about that, and the medical profession, I think, in fairness, they try to think about this in terms of just, how can we put it, sort of objectively about the risks and benefits for the individual patient, or at least that's how they would think about it. But actually then we understand, of course, there's a whole lot of other commercial and other factors then kind of come to bear on some of these judgments at the margin about who should or should not get a particular treatment. And there's tons of evidence from many countries that they're suggesting that there are financial incentives that do play some part in affecting medical behavior and also in affecting kind of system behavior, and that can drive, some systems are more likely to intervene more than others, and some doctors are more likely to intervene more than others. And it's by no means only financial. That is often, sometimes very much reflects kind of genuine beliefs amongst doctors about what is good or bad and where these thresholds lie. But there's a good deal of evidence that there's quite a bit of kind of financial incentivization. What they call supplier-induced demand in health economics is often at work, kind of driving up treatment rates under some circumstances. So that's all pretty interesting.
I remember I have an anecdote about my own experience of that. When I first moved to France, when I moved to France and the year went past and then I got ill in the winter and I went to a doctor. And generally speaking, my experience with the French healthcare system was mind-blowing because, I mean, the fact that you could sort of get x-rays on the same day and you could speak to your doctor on the phone, all this kind of stuff was amazing. But the very first time I went in, I walked out with a prescription for 5 different drugs, and I'd had this cough that wouldn't go away. And I was like, God, I must be really ill. Like, I must have something. Shit, man, this is really, really bad. And I was a little bit worried about it. And I sort of, went to the pharmacist and got the prescription for all the drugs. And it was just paracetamol, different kind of paracetamol, nasal spray. And I was like, I don't, And I called up a friend of mine and he was like, yeah, it's because every single doctor has their own relationship with the pharmaceutical companies, essentially. So the more that they're prescribing you, the more money that they're making. And I was like, that is astonishing. That seems like a very, very, very dangerous way to run a healthcare system. And that was my first sort of experience with how different it could be. And I was very wary going forward with my prescriptions and used to sort of battle with the pharmacist. Like, no, just give me that one thing. Thank you. I don't need all 6 treatments. But on that, I mean, how much healthcare does somebody need?
Okay.
And how is it as well? I mean, maybe we can start to work in the systemic stuff of the fact that surely healthcare at the moment is mostly trying to mitigate against the harms that are caused from our incredibly inactive and highly polluted lifestyles.
Sure. So that's that. I mean, that is the question, obviously, and also, of course, so it's a question that we kind of need to divide up into 2 parts as well, don't we? So there's a question of kind of all of us who've been alive for long enough to be exposed to all of that kind of stuff. What do we need now? And what do we need to change for us? And then there's a kind of more sort of clearly more hypothetical, but kind of and how much can we, by really good prevention, but by prevention I really mean well outside health, if we could do something about all these different ecological factors, how much impact could that make for future generations too? So there's a time question here. Many of us will have been exposed to all kinds of things already that probably are ticking away, and that can't strictly be necessarily prevented now.
Right.
So I think, how I think about this is like this. I think I'll put my cards on the table straight away, and I think sometimes in kind of degrowth world, we get a bit of a story about, the happy paleo people who, as long as you didn't get eaten by the saber-toothed tiger, you'd still be running across the plains at age 100 on your meat diet kind of thing. And I think we need to be sensible about that's just not true. Their children were dying at very high rates of infant mortality, and most people were not making it past their 30s, etc., etc. We do know that, the agricultural revolution did bring in other stresses on health. So like, people's teeth started to go in ways that they hadn't as hunter-gatherers and all that kinds of things. But bluntly, over the longer haul, they did last longer, and more of their children survived, and that kind of incrementally. And then we have the explosion in life expectancy, the kind of extraordinary exponential reduction in infant mortality, which really starts in the 19th century. It lags the Industrial Revolution maybe by, I don't know, 70, 80 years kind of thing, but it's not unrelated to things that the Industrial Revolution made possible. So we have had an explosion in pro-health factors. So, almost everybody having better access to food, particularly sanitation and clean water is the beginning of everything for kind of really good health. Vaccinations, the kind of progressive reduction of infectious diseases through both vaccination and treatments, etc. So everything we then say about the negative factors, which are absolutely there, you just always have to have in mind this incredible increase in human health, which did happen over the last kind of century and a half. And I kind of, it's very difficult. And I find in debates, most people want to gravitate to one pole or the other, and that's just no good. It's just like, both things are true. So with that said, yes, absolutely. A great deal of, what we now call, non-communicable diseases or chronic diseases. So your hypertension, high blood pressure, diabetes, cholesterol, all of that kind of stuff. A great deal of that will maybe come back to mental health issues slightly separately, but a lot of those physical kind of metabolic disorders, etc., very closely related to kind of ecological and social determinants. So absolutely kind of quality of diet, exercise, but also quite direct links to inequality, all of that kind of stuff. So yes, absolutely. We've got, if you like, ecological in the kind of, wider sense of the word, ecological factors driving poor health. Yet, until very recently, we have seen more and more and more people, or higher and higher prevalence of these non-communicable diseases, even as people live longer and longer. So we have to be very careful about the kind of the illness versus the mortality part of these equations. Okay. And I think this is probably, I wouldn't claim that kind of aging and mortality is really my specialist area, but I think we have to be realistic about the fact that I think culturally we tell ourselves a story, which is that we'd all really like to die quietly in our bed, in our sleep, at a ripe old age, not having been ill. That's pretty rare.
Yeah.
Okay. Think about almost everybody close to you who has died. They were ill when they died, and that is kind of part of the process of aging. So I think the idea that we can completely separate out illness from death, I think, is a bit unrealistic. However, the big question that leaves us with is, so we've had more and more and more people suffering these chronic diseases, even while they're living longer and longer. So could we then, in fact, if we did the right things, could we reduce the period of time that people spend in ill health? We're all going to die, fine, but can we reduce the period of time before we die that we spend in ill health? And that's really the big unresolved kind of, not even a debate is the wrong word, that sort of struggle to find the answer of how to do that, I think, at the moment. Perhaps or that has been over the last couple of decades, until I think some of these the impacts of the wider ecological crisis are now beginning to show up and are kind of changing the equation and perhaps starting to at least slow down, if not stop, the continuous increase in life expectancy in the richest countries, and maybe risk of throwing the whole thing into reverse. So you've got all of that happening at the high income end. At the same time, almost every country in the world, not absolutely everybody, but almost every country in the world has seen very significant improvements in life expectancy over the last kind of 50 to 70 years. And certainly every country that's made it to kind of lower middle income country status has really climbed out. Infectious diseases are increasingly not a problem. Their life expectancy is still going up, even as they suffer this same problem of more and more non-communicable diseases. So we got, you've also got this problem of who are we talking about in health always? Are we talking about what's happening at the frontier of kind of the richest countries with the oldest populations? Or are we talking about the big pack in the middle? Or are we talking about the very poorest countries where in many ways some of them still haven't climbed out of the hole of terrible infant mortality? And until you get out of that, none of the other kind of health improvements will come your way. So it's a very kind of complex space. Where are we talking about in those kinds of things? But we know, so in the US in the last decade we actually saw life expectancy go into reverse for several years. It's probably come out of that. COVID has made, the huge impacts of COVID on global life expectancy have made that more difficult to see, but probably they'd sort of come out of it, but they're not really back on track. That was partly to do with overdoses and deaths of despair, sort of somewhat unique to America. But what we saw in a lot of European countries in the same decade was we saw not that life expectancy stopped increasing, but it definitely started to waver. You could see in a lot of countries that it was kind of faltering. But interestingly, that was because older people were no longer living longer. In the States, it was younger people who were dying, and so many younger people were dying that it was actually pulling down the whole of life expectancy. Whereas in Europe, kind of the oldest people were no longer year on year living longer. And a lot of that has really been slated back to austerity after the GFC in lots of different countries in different ways. That seems to have slightly got back on track again. But again, it's hard to tell with COVID because that was such a hit on global life expectancy almost everywhere. So we got a lot of very, quite complicated trends in there. And the difficulty is, we know that we're starting to see particularly climate change health impacts are starting to come up. And, some estimates are suggesting, already maybe sort of single digit millions of people might be dying due to climate change effects kind of already. And that will unquestionably get more and more and more. I think it's, the nature of the health impacts of climate change means that it's quite difficult, other than sort of the edge cases of, you were killed in a bushfire, or, you definitely died on a heat wave day because of overheating. Most of the impacts, it's kind of difficult to really ascribe it absolutely to climate change. So it's kind of difficult to see how that is coming out, but that's clearly going to get worse. And obviously, the ultimate real way that climate change will kill large numbers of people is if we do start to see crop failures. famine is always the greatest kind of cause of death, always has been in human history. Unquestionably, that will drive a huge amount of mortality around the world. So, that there's all of that. Then we have, these complex factors like the plastics and the PFAS and, various other kinds of pollutants working away in the background, which are kind of, I think, the consensus within medicine is increasingly, oh shit, okay, this is real. However, whether we can really say we are seeing those kind of now translating into a greater burden of illness, I think is harder to say. I don't think many people would put their hands on their hearts and say we can unambiguously say that plastics are already killing people, but I think people would be a lot more relaxed about saying it is extremely likely that in a few decades' time the health effects of these plastics, pollution, etc., absolutely will be driving higher rates of various diseases in people. Yeah. So we're at a kind of tricky cusp now, I think. And if you then also throw in, risks of economic, we talked about climate disruption, but also economic disruption, etc., there's a real possibility that we might be around the peak of kind of life expectancy right now. I think that's not impossible. And if we get things wrong, we could easily see ourselves going down the other side as disease burdens grow from pollution, but also just kind of general economic misadventure. I mean, the other thing which makes health care so interesting is that healthcare is so deeply intertwined with economic growth. It's like modern healthcare is completely the child of economic growth. So we don't have a lot of statistics, but one of the best studies there is actually looked at medical expenditures in Massachusetts, and they had data which went back to 1802. And that's probably the longest kind of data set on sort of medical expenditure anywhere in the world. And in 1802, in Massachusetts, about 2% of Massachusetts GDP was to do with medical care. And now, whenever they ended the study in 2018 or whenever it was, it was 18%. So there's two things there. So healthcare has grown as the economy has grown, but actually, and particularly since the Second World War, healthcare has kind of every year grown faster than the overall economy has grown. So again, 1970 in the UK, healthcare spending was probably about 4 to 5% of GDP. Now it's 10%. So kind of healthcare consumes more and more of the economy. So
there's another interesting factor though there, which is women's suffrage.
Yep.
Because in the years immediately after women got the vote, increases in public spending went up by about 30% in most countries. And increasingly women have obviously not only had the vote, but gotten into positions of power as well. So it'd be really interesting to parse that data and see exactly when these increases happen.
Absolutely. I mean, it's hard because, like I said, the real problem here is historically you rarely have the right kind of data to, track back long enough to really see what's going on. So societies absolutely value healthcare. That's been clear. I mean, we wouldn't have spent more and more on healthcare if we didn't. Whatever kind of economic ideology you subscribe to, we can all agree that we've spent more and more on healthcare because it's clearly something that as a society, even as a market, we think is important and of value. So that absolutely unambiguously. But the problem then becomes, when you're thinking about this then from a degrowth frame, is something that has been as growth dependent as healthcare spending, not just growing at the same rate as the rest of the economy, but actually growing faster than the rest of the economy continuously, what happens if you do kind of crudely, go into reverse, which of course, in a planned degrowth is not exactly what we're talking about, but if the economy is no longer growing in GDP terms, what does that mean for healthcare? So kind of let's think of a kind of, if you had a kind of GDP sort of steady state thing, can you make it work to continue growing healthcare relative to the rest of the economy, and how long can you do that for, versus how far can you actually shrink healthcare? So going back to what we were talking about, so a great deal of healthcare is absolutely necessary, some of it is not necessary, and part of it is potentially harmful. So I think we can probably do a reasonable job if we tried hard on reducing the harmful part, but the precise boundary between what is still valuable and what is not valuable is incredibly difficult to actually isolate. So how far can we do that? So that, for me, at the macro level, I think that's the really big challenge if you accept any kind of post-growth framings, which I absolutely do. It actually becomes a kind of almost an operational challenge of, well, how do we keep the show on the road to give people the healthcare that they need, but only the healthcare that they need and not the other stuff? How do you make that work? And that I guess really that's what my work is all about, but I'm not sure I have all the answers quite yet, sadly.
I remember when I was working as producer of Radio Free Sarawak, I used to sometimes interview or speak with a member of the Penan tribe, and they are one of the last properly nomadic tribes in the world, and essentially have rejected agriculture for 10,000 years, and I think has put them in a pretty good position to just mostly keep rejecting things. And for them to live well, they have to live as far away from modern industrial society as possible, which means that when somebody gets really sick and needs a modern hospital, it's a 3-day journey by boat, walking, boat, etc., to get to the hospital. And I remember asking once, why have you made that decision? And it was explained that, well, the forest is our hospital, the forest is our pharmacy, the forest is everything. And for us to function in every other sort of way, for us to continue our way of life and to live as well as we can for as long as possible, we need to live really, really, really far away. And we would rather take that risk than move closer and lose, our kitchen and our herb gardens and everything that keeps us sort of functioning as a society and as individual bodies as well. And I remember thinking about that when reading that degrowth paper that we both spoke about before coming on. And for the life of me, I cannot remember it, but I'll link it in the show notes. And it was about modeling the amount of resources that we need for 8 billion people and 10 billion people to provide a good quality of life according to the United Nations sort of Sustainable Development Goals. And one of the things that they wrote in that paper was that every single person should have access to Swiss level healthcare. And I immediately thought of the Penan people, because I was like, they wouldn't want to though, because the minute that you build in a road to put a hospital near them that they can therefore access in times of emergency without going through a 3-day ordeal, everything around them begins to sort of disintegrate. The ecology that supports them begins to disintegrate. So I just quite like to continue that conversation we're having before I hit record as well. That how is it that we do, in that respect, measure what people need? And how is it that we can, what am I trying to say? It's not just about the individual body, as you were sort of pointing out, with regards to what they may or may not need. Yeah. It's also about what the culture might need as well, right? And that allowing people the opportunities to frankly still say no, if that is what would have the biggest net benefit to them. So can you speak to how they measured that in that paper?
Certainly. Well, so in that particular paper, from memory, I think their kind of healthcare measure was actually about, they looked at each country and they were saying that you should have a certain kind of, it was like a square meterage of hospital facility availability per country, which I think, as you say, I think maybe was based on Swiss hospital systems. I think in fairness to them, they weren't necessarily saying everybody had to spend as much money as the Swiss healthcare system spends, which I think is number 2 spender in the world after the United States. Gets much better value out of that spending than the US does. So I don't think they were actually necessarily saying it was like the Swiss healthcare system, but it was like a measure of hospital kind of physical hospital capacity. And I mean, I think there's it's entirely fair to have a go. And as we were talking about, one of the problems is when you do these studies, like the kind of the decent living standard studies that like that, you do have to, you've got to think about, well, what are the factors, the basic needs people have: education, healthcare, sanitation. Then you've got to come up with some kind of measure of, well, what's the kind of minimum satisfactory access that you have to those kinds of things. Sometimes that might be easier, so it's probably easier to say, how many liters per person per day of clean water do you need? That's probably not so contentious, whereas of course, getting into what kind of level of healthcare do you need is to turn it into one measure to put into those kinds of models becomes very complex. So I think I can understand why they had a go at that. I think the problem is stepping right away from kind of degrowth and things, even just kind of very conventional approaches to how we measure health system performance. We would rarely say that hospitals are the most critical part of the healthcare system. Indeed, really, my whole career, we've always spent all our time talking about how can we actually minimize the hospital end of the system, and how can we actually do more primary healthcare in the community, and how can we keep people out of hospital. So I think specifically using a hospital measure is possibly tricky. I think if they'd asked me, I probably would have gone for a simpler measure about kind of numbers of doctors and nurses per capita or something like that. Actually, I think it's pretty crude still, but I think that perhaps would have been a kind of slightly safer version. I mean, what we know from the research we've been doing, we've done some kind of not quite the same, but in the same sort of space, statistical analyses where we've been trying to look at, firstly, kind of how does healthcare spending per capita relate to healthcare outcomes. And more recently, we haven't quite finished it, but I think we know where it's going. Then also do similar kinds of analysis looking at energy per capita and health outcomes. And I think we're getting a fairly sort of consistent picture. So what you see, and obviously, expenditure and energy, as we understand, they're very tightly linked, as all these economic variables are very dependent on energy. But let's just call it resources, for want of a better word. So whenever you start, if we look at the very poorest countries who have incredibly low spending on healthcare, I mean, there's 2 orders of magnitude between the lowest spending countries and the highest spending. So, for example, in, I think this is maybe 2018, I think it was the lowest was the Central African Republic, which was maybe $23 per capita per year spending on healthcare, versus over $10,000 per capita per year in the United States. So it's like extraordinary differences between countries. But those very poorest countries, as you put more resources in, so as either health spending or kind of energy consumption goes up, you get an almost vertical kind of improvement in whatever measure of health you want to put in, whether it's life expectancy or infant mortality or health adjusted life expectancy. There's all kinds of measures, but you near kind of vertical line. So you get incredible improvements in health as you invest in the most basic infrastructure of healthcare. So that's like vaccinating children, that's making sure women have access to some kind of skilled birth attendant, essential medicines just like antibiotics and things from very basic primary healthcare clinics. So you go up incredibly fast. Then we get up to kind of levels of resources that you see in lower middle income countries. So those countries tend to have fairly well established primary healthcare systems, and then they're kind of starting to put more resource into the hospital system, more advanced diagnostics, stuff like that. And we see you still get very clear improvements in health for every sort of extra dollar or unit of resource that you're putting in, continues to go up until we get up to the kinds of levels of resource that we're seeing in particularly the kind of southern European countries. So high income countries, but if you like, the kind of lower end of the high income countries. So places like Spain, for example, often comes out very well. Italy often comes out very well. After you move past their level of resourcing, we're typically seeing almost no further improvement. And then right out at the far end, where it's very difficult to tell statistically, there's possibly the whisper that very high levels of spending might actually be worse for you. Now, I would not say that anybody could statistically prove that Americans are sicker because they spend so much on healthcare. I don't think it's as direct a relationship as that. But what you do have is absolutely the Americans, but also even the Swiss, with their incredible spending, are not the healthiest people in the world. And the healthiest people in the world are clustered much more, as say the Southern European, maybe Singapore, places like that. So it's kind of interesting. So the question then becomes, somewhere in between the first turning point in the lower middle income countries and the second turning point kind of up at the end where upper middle income countries are turning into high income countries, perhaps somewhere in there is, if we did everything right and we could be much more efficient, maybe there's something in there. The challenge is that our analysis that we do is all kind of backwards looking, so we're using historical data, and the kind of the awkward thing is that the sorts of numbers that we're landing on are for kind of what would really be well met basic needs without excess healthcare. That's still higher than what the kind of planetary boundaries type of people would be telling us is the likely kind of safe energy and resource use overall. So the challenge
to meet basic needs.
Yes. So the challenge therefore is, how can we kind of pull that in? So I think the kind of some of the very basic needs, the decent living standards, basic needs stuff, I think would have I'll be blunt, would have a level of healthcare which would be an improvement for maybe the lowest 25% of countries, but actually might be quite a significant reduction in access to healthcare for most countries. And that's challenging. And I'm not so sure that at those levels you would actually, you wouldn't have a reversal of health status. So I think what we're saying is, I reckon there is a place that we can get to the balance. And I reckon with the right work, you could bring that closer. But how do we bring all of this close enough to meet? I think that's the challenge there, isn't it?
That's really interesting. I don't know how much I think that thinking about how to degrow certain industries like health it feels quite instinctively frightening.
Yes.
Well,
it's not the place you would necessarily start. I'd certainly list.
No,
and that's often what I get. I often people go, well, why are you
hang on,
about
Martin,
health?
please.
Sorry.
Thank you. I think it's always felt quite instinctively frightening to imagine degrowing healthcare out of that sort of very intuitive, but also very, very clear data that we have that we are well overshooting Earth's boundaries. And there's a lot about the way that human beings live in modern times that just simply cannot be replicated if we want to support everyone, including the more than human world. But I have to say, even with that instinct, I am surprised to hear that even sort of fulfilling a basic level of healthcare may very well push us over Earth's planetary boundaries. I mean, if I go back to what I've written down, you mentioned vaccinations, antibiotics, even women's access to education. I mean, I guess I had assumed that if it was as simple as sort of like sticking needles in people's arms and, you know, giving them a couple of pills in an emergency, that we would have been able to do that. What is it, if I can ask, and this might be a really difficult question, but like, what is it about those things that makes it, that puts a pressure on Earth's resources? I mean, I don't even know this, but where do we get antibiotics from? Where do we get vaccinations from? How resource intensive are these very small things?
Sure. So firstly, just to be clear, so when I say won't have the resources, I mean kind of for in the kinds of analyses that these people like the Decent Living Standards people do, you know, they're giving health a kind of share of the budget, if you like, of natural. So I'm not saying the healthcare system consumes everything, obviously, but you know what slice of the pie can go to health, clearly. So just to be clear about that. So I think so you've got a couple of things going on. So firstly, those very basic, most critical interventions. No, I would agree that I think we can do those things well within the kind of ecological resource constraint. But I think that is something that looks so different from the healthcare systems that even people in middle income countries are accustomed to, that I think we should have our eyes open about what we would lose through that. So, for example, in a kind of system, that's the kind of system that for many years, the World Health Organization has been trying to ensure in the lowest income countries that people have access to that very basic primary health care. And we've been struggling to do that in those countries. But what do you not get from one of those systems? So many people, if you only have access to those kind of essential packages, many, many more people would have to live with disabilities that in a better resourced place, those disabilities are not kind of life limiting, either in terms of how long you live or how you live your life, but with only that access to very essential medical care, a whole lot of people with disabilities, the way they could live their lives would be completely different, not in a good way. So I think it's that kind of thing, and very much about how much care really would older people really have access to, what level of care might you have access to if you develop cancer, that kind of stuff. So those are where the challenges and the trade-offs there. There's something essential care, I think, is manageable. So how do we go up from there? How does healthcare contribute to the ecological crisis? So that's a great question. So the first and most obvious way is, as I say, healthcare is big. So in high income countries, 10% of GDP, maybe 6 or 7% of greenhouse gas emissions total kind of end up going through the healthcare system, depending, of course, on your energy sources. So, if your country is entirely renewably powered, your healthcare system probably won't do much in the way of greenhouse gas emissions. But if your whole economy is fossil fueled, the healthcare system will be pumping out its share of greenhouse gas emissions. So greenhouse gas emissions important. We cause quite a bit of pollution. So the kinds of pollution that the healthcare system drives are, particularly we use a lot of plastic. We saw that very much in COVID, with all the, PPE and gloves and wrappers and stuff like that. There's a lot of work being done on how can we reduce plastics use in healthcare, both sort of plastic substitutes, but actually also, just how can we reuse instruments, devices, etc. We used to do that 40 years ago, and then particularly because of mad cow disease, ironically, everything went to kind of single use. How can we move that back again? So there's a lot of work going on there, but we generate a lot of plastics waste. We generate so pharmaceuticals are also super interesting. So pharmaceutical life cycles of pharmaceuticals. A lot of pharmaceuticals, their active ingredients and lots of components are themselves fossil fuel byproducts. Right. So quite a lot of the chemical feedstocks are kind of cracked during the whole refining process. So they're kind of byproducts of fossil fuels. So that's kind of interesting, is if you move off, if actually we got ourselves off fossil fuels, can we necessarily, not still need some of those byproducts? Are we actually still going to need to burn or flare and refine some
because they're not at the top
still, because we need these things, etc., etc. So that's interesting. Lots of chemistry work that I don't understand, but trying to look at, kind of, are there greener chemistry alternatives to that? Tricky though. Some pharmaceuticals are directly sourced from the natural environment, and we have a kind of unfortunate tendency, I think, to find that some of the best active ingredients come from terribly endangered ecosystems. Yes. And we've got a nasty habit of, great drugs that do amazing things, but it's sort of, oh, look, they all come from this, kind of 100 square kilometer piece of jungle over here, and nobody finds them anywhere else. That kind of, so that's problematic. Lots of interesting work on kind of how can you synthesize those compounds, but I think that's kind of not going to go away. You see change in the availability of some of those natural compounds, particularly due to climate change. So you're seeing what do they call it? Changes in the range. That's the right word, I think, isn't it? The sort of the geographical range of where many of the particularly plants are found, and risks that they might be at risk due to climate change impacts themselves. Lots of interesting kind of stories there. But then at the other end, we have a real kind of problem with pharmaceutical pollution. And the biggest source of pharmaceutical pollution by far is actually us. Because when you take a drug, typically somewhere between 30 to 90% of the active ingredient passes directly through you, unchanged, unmetabolized, and directly out the other end when you go to the toilet. And so that then makes its way, if you've got wastewater treatment systems, that makes its way into the sewage system and out then into the natural environment. And in most countries, even in very rich countries, it's extremely expensive to have the kind of it's not even filtration, it's a kind of ionic systems that extract these pharmaceutical metabolites out of the wastewater. So in most places it's going out into the wastewater. In other settings it's going directly into the natural environment. Then it can be recycled. So for example, they use, lots of places use the sewage sludge goes to be used as manure fertilizers in agriculture. So then that's going into the crops and into the groundwater. So we've got particular worries. There's various drugs which we know are quite disruptive to all kinds of different organisms. I had a fantastic student who's just finished her master's thesis. She was looking at antibiotic resistance in pollutants in the environment. Sort of most alarmingly, there are some antibiotics which actually affect algal and other bacteria in the marine environment and cause them to produce more methane. So there's actually a sort of horrible feedback loop potentially there. I mean, I can't tell you how big that is. This is certainly not going to be the biggest driver of greenhouse gases, but there's all these kind of loops going there, and really fascinating examples where we're beginning to see how drugs are actually impacting on different organisms. So, the most extreme one is in India. They were using a drug called diclofenac. They were giving it to cattle agriculturally, and unfortunately diclofenac proved fatal to vultures, and as a result the vultures were eating the dead cattle who'd been taking the diclofenac. That caused a massive die-off in vulture populations, leaving the cattle carcasses uncleaned by the vultures, and that actually started to then cause infections in human populations. So there's actually shown how that has led to increased disease in humans in the villages around. So you've got that through to various birds and fishes showing behavioral changes due to exposure to psychiatric medications in water pollution. Yeah, so it's quite extraordinary sort of chains of impact going through, not many of which have yet really, shall we say, proved themselves to be catastrophic, but just the fact that you can see these effects is obviously deeply, deeply worrying. So, one of the things we therefore have to do is, coming back to this kind of how much is enough question, is really make sure you're only taking strictly the pharmaceuticals that you absolutely need. That's the starting point and the simplest way in, whilst they work on very clever kind of biochemistry solutions. There possibly are ways that we can design drugs so the active ingredient is kind of metabolized more effectively in the human body and not passed through. There's possibilities there. But so pharmaceutical pollution is quite a big one. And then when we think about the antibiotics, the other big threat we haven't talked about, which is the spectre sitting, but I'm talking about how can we keep the modern healthcare show on the road in a different future. One of our greatest risks is antimicrobial resistance. So as we see more and more resistance to more and more antibiotics, that's a real problem. It's certainly made worse by pharmaceutical pollution, so we're actually worried that we now might have kind of factors driving antibiotic resistance out in the natural environment because of pharmaceutical pollution, along with its overuse. But if we lose antibiotics, then we suddenly, quite quickly, will not be able to do lots of the things which we now take for granted. So, if we don't have antibiotics, we will only be doing surgery when it's actually life-saving.
Yeah.
We won't, you probably won't be getting a knee replacement anymore because the risk of you dying of an infection because of the surgery will be so much greater than it is now. So it's a real danger that we'll lose a lot of the utility of modern medicine if we can't get on top of antimicrobial resistance.
Well, Martin, it's a grim outlook, I'm not going to lie.
That's what my colleagues tell me. Yes.
Yeah. Not looking good, but not surprising. Definitely fits in with the trend of everything else that we know about this state of the world. And I do feel like we've only sort of scratched the surface, but I'm also aware of time and that you have to go. So I think let's leave it on that very depressing, very scary note.
Yes.
Although one thing that people can go off and look up themselves is why it is that Southern European countries are the healthiest, despite, I mean, listen, having lived there, everybody smokes, everybody drinks, and yet they are doing something right.
Yep.
And I can tell you that they are probably like the most anti-capitalist organized people in the Western world.
Absolutely.
And I am sure that that is something to do with it.
100%. And we haven't even talked about all the mental health and
I know.
where's all that coming from. Absolutely. So 100% agree, yes.
We'll have to get you back on the show to dig into all of that. But my final question before I let you go is, who would you like to platform?
So having had a good old look at who you've already had on the show, I thought, yeah, that's challenging. Most of my thoughts had already gazumped. But I think right back to what we were talking about at the beginning at greed, and actually a very different Christian perspective on greed, is a super fantastic bloke called Malcolm Foley, the Reverend Dr. Malcolm Foley, who's based in Texas. But he's got a newish book out, which is called The Anti-Greed Gospel. And it's super interesting. And his core thesis is that actually greed is, in fact, the basis of racism, and particularly the basis of racism in the US and its whole history. It's a really super book, and he's a very, very, very good speaker. So he might be somebody, different, but really quite interesting. Yeah.
Great. Do you have any other health economists as well?
So I think I'm probably going to upset my health economist colleagues, because she's not exactly a health economist, but a great colleague who is at the Australian National University is Sharon Friel. And she's done a fantastic amount of work on what's called the social and commercial determinants of health. So she, far better than me to talk about this, why is modernity making us sick, with all my caveats about how even though we've still carried on living longer all the same, but she would be fantastic to talk about, yes, how is modern society and what she calls the consumptogenic society, why is that making us sick?
Oh, what a great word. I've never heard that before. Okay, Martin, thank you so much for your time today. This was extraordinarily interesting. Thank you for coming on.
Thank you so much.
If you want to learn more, I've put links to everything in the description box below. Remember to subscribe to the channel if you're new here, and share the episode if you enjoyed it. To support the show, subscribe at planetcritical.com, where you can read the weekly newsletter. You can also become a Planet Critical patron. All links are in the description box below. As always, my deepest thanks to that community. Planet Critical wouldn't exist without your support. Thank you everyone for listening and for coming on this journey together.